Welcome, welcome, everyone. Welcome to our today's training on clinical assessment in marriage and family therapy. The honest to God truth is clinical assessment is pretty consistent across all the mental health disciplines. We'll talk a little bit about how it's, some of the unique dynamics when you're working as a marriage family therapist. But it's going to be a nice introduction to clinical assessment in couple and family therapy. And we'll be talking about um, how to use some of the forms that go with my textbooks. So let's talk a little bit about the purpose of clinical assessment and diagnosis. And certainly within the field of family therapy, you also will see it in counseling and social work, less so in psychology. There has been some critiquing about diagnosis. Um, in terms of it's, you're labeling people, right? And sometimes, diagnosis can be used in a way that is really liberating. And there certainly are times where people get diagnosed either incorrectly or the diagnosis adds to more shame and can make it more difficult. And so there's a lot of clinical nuance in how to use a diagnosis in a way that really promotes someone's lifelong wellness. But the basic purpose of diagnosis, and it is generally considered, I would say, an ethical requirement in most cases, in most clinical practice environments, if you're working as a licensed or, under the supervision of a licensed mental health provider, pretty much in the 21st century, I would say diagnosis is required. There was a time when I practiced 30 plus years ago. There's a point where you just stop, after 30, I don't count, where there was a lot of debate around this. Humanistic and postmodern systemic therapists from all different disciplines were often very anti-diagnosis, and there was a time in mental health history where some folks didn't diagnose for philosophical, theoretical reasons. They didn't feel like it would promote the wellness or that it was necessary. I would say at the very least in today's 21st century that there is doing a clinical diagnostic, what we would call the DSM diagnosis in the United States. There is the ICD that has very similar diagnoses, nearly identical, that is used internationally. But doing some sort of mental health clinical diagnosis using standardized diagnoses that are recognized by the World Health Organization and the American Psychiatric Association is pretty much ethically required in most contexts. And the main reason is you're ruling out, you're trying to identify the best treatment option. What does research say that works for a certain problem? You're also, this is key to helping people be safe, right? And identifying the need for potential services, whether or not you're the right person to help this client. So there's this ethical mandate because safety is involved. You need to do diagnosis to ensure safety and that you're the right person to work with this type of problem and to make sure they're getting medical care if necessary, and also to help coordinate care with other professionals, to have a common language across disciplines. And so also with diagnosis, you're looking at determining the level of care and determining what treatment's going to be the best option for your client. And if you come from a position where you're very concerned about how diagnosis can potentially have negative effects on a client, I would say, then getting good at diagnosis is really important. And, I was, I did my early training in very postmodern circles in terms of narrative, collaborative, solution focus, and even systemic, most of the early family therapists are pretty anti-diagnosis. But I think it's really important if you're concerned about how giving your client a label like this might hurt them, getting really good at diagnosis is really important. There are times when I have been able to really advocate for my clients because I could say, no, this is not borderline personality disorder. This is a trauma reaction. Give me 2 years to work on the trauma and we will not see these borderline behaviors, right? And so this was someone who was in a large county system, and it really was able to help them and get them treated better throughout the system. So there are, understanding how to diagnose well is really an important skill if you want to be an advocate in the field for your clients. So let's look at diagnosis and our inescapable cultural lenses. I love that we have so many folks here today from around the world, because different expressions of different diagnoses, such as anxiety or depression, right? They can look different across cultures, across ages, across generations, right? Even in different parts of the country and the world. So, and just in terms of even geographical differences. So it's really important to understand and be aware of your own personal culture, values, your family, your personal history, family history, beliefs and norms. I mean, even if we just look at, like, you come from a family that's more of a collectivist cultures, versus a more individualistic culture. Your ability to assess boundaries, normal expression of emotion is very much contextualized by how your family, handled boundaries, how they expressed emotions, whether you're male or you're female, or you have, another gender identity, and those expression of emotion is highly gendered, right? So very culturally defined. And then you have all the generations, right? So there's so many different lenses to be considering, and knowing, how your family and how you personally approach emotions and express emotions is going to have you view someone's symptoms, whether it's depression or anxiety or panic or ADHD, right? All of that, you're looking what's normal, what's not. You've got your lenses on it. It's very important that you're aware of those. None of us are neutral. We all just have different perspectives that we look at folks from. It took me a while. I come from a very communal culture. My mom was Greek. I grew up very much in this extended Greek family. So I'm used to like 20 people around the table, for a holiday. I mean, it's not a holiday unless 20 people are there, right? And so when I would hear about these people who had like 3 people, for their Christmas celebration, I'm like, four, just the nuclear family, I'm like, whoa, that's kind of weird, because it was different than what I grew up with. And so learning how to see through your norms and your history is really important. And so, and even just being aware how our professional training brings in new sets of lenses. Oftentimes, for those of you who are in graduate school listening to this, when you go through your first, course on how to, reflect emotions back and do your basic counseling skills, most of you are going to then observe clients, especially your male clients in relationship, and going, wow, they can't talk about emotion. They can't do empathy. I'm like, no, they've been socialized not to, but all of your professional training has got you thinking that that's like a normal basic skill. So just even realizing our professional lenses have values embedded in them as well. So it's a real important place to be considering and becoming very familiar with what is your norms, what are your values, how your family did things, how you do things, and realizing how that can affect what you're observing in clients. So like I mentioned, that psychiatric diagnosis has been criticized for being pathologizing, especially of feminine traits and behaviors. And so that's something you need to be very aware of when you are using these, doing diagnosis across genders, across cultures, across ages as well, and generations now. I think we have such distinct personalities across, or ways of handling emotions across generations. So being aware of the gender bias that is in a lot of our diagnostic manuals, and being thoughtful of that. And then on the flip side, there are also folks who will argue that men are being underdiagnosed, okay, and therefore undertreated. So being thoughtful of how, what your expectations are around, whether you're looking at something like ADHD or depression or anxiety, and how that can look really different across different expressions of gender. And then we also have looking at social justice issues across diagnoses. And so there is, just so you know, in the DSM-5 and the DSM-5 TR text revision, there's a cultural formulation and interview protocol that was developed by a team of international experts in the area. So the DSM, even though it's published by the American Psychiatric Association, it is created by teams of international experts from around the world for all the chapters, and it very much closely works with the World Health Organization to address that. So looking in terms of considering how culture might be informing a person's expression of their emotions, their and any type of mental health issue is very much informed by cultural norms. And there are some cultures where it's more common to have like physiological expressions of a psychological issue. And so there is, the DSM, it will talk about some of the unique cultural expressions of mental health or psychological issues. And so, and in any case where someone is ostracized or marginalized or been abused, you want to consider all of those dynamics when making a diagnosis. And even if they're just ostracized from within their family or within their local community, it doesn't always have to be along very obvious lines like age, gender, race, ethnicity, sexual orientation. It may not be some of the big ways that people get ostracized, but even marginalized within a family or a community. And so being very aware of just their experience, and then also their experience around other professionals, health professionals. If this is someone who's been in the system a lot and they've had some really bad experiences being treated either in the physical health or mental health, what you're seeing is also a reaction to all of those experiences of being marginalized, and to just be aware of that or feeling misunderstood. Just being very, very thoughtful about who your client is and their experiences and how they might be, what they might be bringing to the table. So let's look at specifically mental health diagnosis in family therapy. So, within family therapy itself, if you look at the systemic traditions, they will look at an individual's mental health symptoms as being embedded in the larger family system, right? And so, even though the person may be, experiencing um, or sometimes I would even say doing depression or doing anxiety or doing hyperactivity or inattentiveness, whatever they might be doing, or even doing psychosis, they would say that that particular person we need to consider the family dynamics and the role that that symptom plays in maintaining the family homeostasis. And so they always look at, even if there is an individual, maybe the symptom bearer is a term that they would use, or the identified patient, the IP, or the symptom bearer are two terms you'll hear in systemic therapy. They're looking at how that particular set of symptoms makes sense in a given family system. For example, some people end up doing depression, and very common hypothesis, in family systems work, especially earlier family systems work, that oftentimes what you would see is that a child who is experiencing symptoms like depression or conduct disorder or whatever it might be, would sometimes serve the symptom to unite a couple who otherwise, might be struggling in terms of their relationship. And so it becomes this unifying um it unifies the couple, or and they rally around the child, and it calms down the couple conflict. And what you find in systems like this is, as soon as you get one kid's symptoms, they stop acting out, they stop being depressed, their ADHD or whatever gets managed, you will see that another child suddenly starts developing some kind of symptom. And so when you start seeing that symptom move around between children, that there's often a homeostatic mechanism where the kids' problems are stabilizing the couple marital subsystem. And it's hard to believe till you see it. I remember the first time I saw it, where we had the child who's been the problem child, right? And they come see me for a few months, and all of a sudden the problem child's doing much better. And all of a sudden the perfect child, the angel child who never did anything wrong, starts spiraling out of control with crazy problems. I was like, no way, this is what they were talking about. It is happening right in front of me. So, and when you really experience that for the first time, you begin to get what they mean by the identified patient. And, in those types of symptoms, you really have to address the couple issues in order for the kids to stay symptom free. And you will see that. Now, Is every time a kid have a symptom, does that mean that they're stabilizing the couple? No, it doesn't mean that there's always couple conflict that they're stabilizing, but it's something to be aware of. And when you start seeing that those symptoms move between kids, you're realizing that that depression, anxiety, or ADHD it has a homeostatic function within the system as well. It's something to be aware of. From a postmodern perspective, they're postmodernists, and to some extent, even a lot of the humanists, are very concerned about how these labels shape a person's identity. And so, if a person's diagnosis, let's say they get depressed, let's just say they get major depressive disorder, right? And that can sound very medical, very heavy, and very much like, now someone's got to tell me, I have to do X and Y and Z, and this is heavy, and this is bad, and this means I'm weak. And they can have all of these other kind of discourses, and that diagnosis can really shape their identity. And so, often from a postmodern perspective, it's like, what if we just say the person is blue or going through a rough patch, or however they describe it? When you stick with that description, the problem is actually often easier to address. And so there is a dynamic to this that I have also experienced a lot of truth with in my work. And when you can come in, I remember once I did have a child who was having a lot of conduct issues, and he was like 8. He came in, and the school had sent him because he was acting out. And and so when I was talking with the family, or the mother and the son, the mother was like, he's amazing at home, he's an angel at home, he helps me all the time. There's a new sister, he had a new baby in the family. He'd run and get the diapers for the mom, whatever the mom needed, he'd run and fetch it, and doted on his little baby sister. And he was just like, flawless at home, easy, no conflict issues. And so, we came up with the idea, well, wow, what would it be like to help the teacher a little bit like you help at home, And and that label of helper, he enjoyed it so much at home, and he went to school, and he started trying to find ways to be helpful to the teacher. And I'm not kidding you. It was one of my, one session cures. I don't have too many of these stories, so, but it is a real one. I'm not exaggerating. Within a week or two, he had totally changed his attitude, at school. He shifted to be a helper at school the way he was at home. He enjoyed that identity. And and I will tell you, that sort of miracle cure around identities normally only works with kids who are 10 and under, but it does happen, and enjoy it when it does. But these labels really can affect us. Getting the label of ADHD, getting the label of autism. What I've been seeing in the last few years is that a lot of people actually will get a label like autism or ADHD, and they just cling on to it. I once had a kid, this was older, but we were trying to do a family session. He had been diagnosed with ADHD. And I was trying to get the mom to have him sit in the chair so we could talk. And he just stopped. I remember he stopped, and he just looked at me, and he said, I am unable to sit in the chair because I have ADHD. And because I have ADHD, I don't sit in chairs. I'm like, okay. He clearly someone was trying to explain it to him, and it didn't quite land right, right? So, these labels can become self-fulfilling prophecies. And I do think it's problematic when people really build their identity and they cling on to, even trauma. Trauma is highly treatable. And so there's some folks I know who just hold on to that I was traumatized identity, and it's highly treatable. It's not fun to treat. It can take, a year or two to treat, but it's highly treatable, and we're going to get you through this, and you're going to have a normal life. And that's, so it's real important that we are able to talk to our clients about their diagnoses, and really note whatever stories they're telling themselves about their diagnoses, and to make sure that that if we, these diagnoses are used in ways that liberate rather than imprison our clients. So, in terms of, if family therapy and a family therapy assessment, compared to some other approaches from a family therapy approach, the diagnosis is a relatively minor part of systemic case conceptualization. So the question would be, how does the presenting issue, if it's individual, like, depression, anxiety, ADHD, how does that function to stabilize the family? How does that fit into the whole family system dynamic. So it's a small part of a much bigger context, and you're looking at the relationship and, of course, community and even societal concepts. How does this symptom fit in? And you're looking for the pattern. You're not just trying to get the diagnosis, but looking at the interaction patterns around the diagnosis and how they stabilize them. This is very well documented and established with issues around alcohol and substance abuse, right? If you just go get somebody clean and sober, when you just drop them right back into the same couple or family system, the relapse rate is going to be very, very high because you've not shifted the relationship pattern where the substance use made sense. So, and if not, they're going to suck them back into that relationship system. For example, let's say I've worked with several families where the husband was using substances, the wife and slash mother had been doing all the caretaking of the kids, managing the house, but she made all the decisions. And she had a lot of power because he wasn't involved, right? And then he gets shipped off to 30 days in his treatment center. He comes back, and now all of a sudden he wants to, make half the decisions. She's like, I'm not good with this. And they start fighting. And guess what? Within a few months, he's using again. So you need to make sure that you pay attention to these broader family dynamics. And so finding the proper place for diagnosis in your conceptualization, it's one of multiple possible descriptions that are useful. And there are times where I would say that the diagnosis is very useful. There are other times where it's almost a distraction. And so there is this taking time to really figure out how best to focus on that diagnosis. Whether, it can help, inform treatment planning, such as with substance abuse. But oftentimes when you're trying to inform an intervention, the actual diagnosis is less important than all the dynamics and how to intervene around the actual dynamics. Because, for every person who has depression or generalized anxiety is a very unique experience of it. And so understanding all of the dynamics around a person's experience of depression or ADHD, and how to intervene is going to really involve this broader systemic level of assessment. So let's look at some of the contemporary issues. So one is the DSM-5 came out in 2013. It was revised, I believe, around 2022. And it's, I just want to quickly just touch on, it is a very interesting document. It's even been called a bridge document. You should read the first introduction. Everyone skips the introduction. It's really worth reading, I'm telling you, because I did get trained. I was the American Association for Family Therapy, asked me to do the training for AMFT. And so I ended up going to the trainer. And I was really heartened to hear, some of this, but, we're moving away from, all of the labels and diagnoses and moving towards more what they're calling a dimensional assessment approach, where you'll hear about these cross-cutting symptoms. There are cross-cutting symptom measures that come with the DSM-5 for free. They are outstanding measures developed by leading experts, but it's going to be more like a blood test in the sense of it'll be, what we're looking at in the DSM-6 or 7 is something more along the lines of you have mild, anxiety, moderate, depression, you have zero substance use, you have, moderate sleep problems, but you're going to have these 13 cross-cutting symptoms, and we'll be looking at how those things line up, whether they're, not an issue or mild, moderate, severe for each person. So, as a clinician, that makes a lot of sense for us. I think the diagnoses make a lot more sense for psychiatrists who have to prescribe medication. But when you're working, as a mental health professional doing psychotherapy and family therapy, the diagnoses are less useful, I think, than if you're prescribing medication, because you do have, normally when you have someone with depression, there's a lot of anxiety going on. There's often relationship conflict, and then there's a sleep issue, right? So you've got all these different dynamics going, and just giving it one label, it's easy to miss some of the subtleties of what we're working on. So you will hear more about these cross-cutting symptoms going forward. And so So this is kind of an exciting kind of future of diagnosis. And if those of you who are new in the field, you'll be shocked at how different what you're going to do in 10 years is from what you're doing today. There is, like I said, a cultural formulation towards the back of the DSM-5, both the 5 and the 5TR. That was developed by a team of international experts, but looking at how the culture that the client's culture would be defining the problem, the cultural perception of what the cause could be, what the context is, and what type of support is appropriate. Looking at unique stressors and supports due to their social location. Looking at the client's cultural identity. I mean, maybe just because you label them, in the United, as a professional might label someone, XYZ, is that how the clients are labeling themselves, right? That's there's an important distinction there, and making space and making sure you're having those conversations. Looking at cultural factors relating to, self-coping, how do they cope? And then also, seeking help. Both in the past and in the present. So there is some guidance in the DSM for thinking about these cultural concepts.